Myself, Rajendra Sahu, I am the Secretary of the Bhubaneswar City branch of the ISSP. We have recently started the academic webinars from our city branch, and this is the second webinar from our site. And in this webinar, we are really fortunate and feel privileged that we have a world-renowned and eminent speaker with us. He is none other than Professor Philip Peng from University of Toronto, Canada. So I had the proud privilege and honor of working with him for 2 years during my fellowship at Toronto Western Hospital University Health Network, Toronto, Canada, from 2015 to 17. And Dr. Peng, despite his busy schedule, agreed to deliver a lecture for our webinar today. So to start with, let me have a brief introduction. As I read out his biodata briefly, it is an honor for me. He is the professor in the Department of Anesthesia and the Pain Medicine at the University of Toronto, Canada. He is a leader, researcher, educator, and pioneer in the application of ultrasound in the pain medicine. His contribution for the pain education resulted in founder status from the Royal College of Pain Medicine, Canada, and also the award of recognition for education in pain medicine by ESRA, European Society of Regional Anesthesia and Pain Medicine. His innovative research led to different new procedures in pain intervention. We must, all of us know about the Peng block, PENG Peng block for the hip fracture, hip surgery, and subsequent its application for the hip analgesia in terms of radiofrequency ablation also. So he has received numerous awards, including the topmost awards like John Bonica Award from the ASRA, American Society of Regional Anesthesia and Pain Medicine, Distinguished Service Award from both European Society of Pain Medicine Spain and Canadian Pain Society, Gold Medal Award from the Canadian Anesthesiology Society, International Distinguished Career Award from Mexico Pain Society, Leadership in Advocacy Award from CSF League Canada for his intracranial hypotension. He is the inaugural fellow of ASRA, fellow of American Society of Regional Anesthesia and Pain Medicine, which recognizes his contribution for prominency in this field of pain medicine. He has delivered more than 600 lectures and workshops nationally and internationally. He has edited 8 books and published more than 256 to 260 peer-reviewed publications in various journals and book chapters. So we have read numerous of his publications with regards to knee innervation, denervation technique, adductor canal, hip, shoulder innervation, and so on. And also his very fantastic MSK ultrasound pain intervention step-by-step approach book also, which was published few years ago, in addition to few other books. Now that with this brief introduction, let me invite our distinguished guest today, the speaker, Professor Philip Peng. Professor Peng, over to you. I request everybody to keep themselves muted throughout this meeting, and whatever questions they have, they can write down in the chat box. Professor Peng will be more than happy to answer those queries at the end of this lecture.
Let me just see. I tried the slide and see whether it's still working. So, good evening. It's a morning in Canada. Good evening, and thank you for all you to tune in on Sunday evening. Thank you, Raj, for the invitation. It's always a pleasure and honor to reach out to my friends and colleagues in India. For those who know me, I have a lot of interest and investment in the understanding of the innovation and the innovation of the knee. The last 5 years, there were a lot of publications, and I witnessed a lot of teaching, workshop, and from different individuals. So, and I actually really admire the energy. But when I look at those publications or those teaching, many of them are very good, but many of them, they are just a little strange. So after some years, I think enough is enough. Maybe I just try to help everyone to navigate those controversial and unclear topics. So recently, we published a paper summarizing all this, and instead of pointing fingers, so which is not my type, I summarize all the evidence all the information from the literature and navigate through those controversy. So this is what I'm going to share with you. But in this spirit, I hope that one of the message is I pledge to all of you, don't kill the messenger in case something that you don't like, and we talk about science, okay? And a lot of those slides are coming from my free books. And the article I'm talking about is this one. So this is the one that I work with three physiatrists from Spain, and with my supervision, we work very hard for a whole year and navigate all this information. Okay, just cut to the chase. We have a lot of things to unpack. I do actually have much more in my article, but for the interest of time, I just talk about a few things. One is the use of a prognostic block. Everyone have their own opinion. So the one that say that we don't need the prognostic block because there's a restrict pain generator. For back pain, we have myofascial pain, discogenic pain, pain from a ligament, pain from the facet, pain from the bone. But for osteoarthritis, the pain generator is from the within the capsule, so it's restricted. And the literature really suggests that in general, if you do this, probably 80% they are positive anyway. And this actually is fairly common for my practice in early part of my practice. Okay, so I emphasize in early part. When you see more and more complicated patients, things are different. And the third reason that people say you don't need prognostic block because there's a trial from the Utah group. They say actually, whether you do prognostic block or not prognostic block, the outcome is basically similar. So there's no need to. We go back to this in a moment because there's some major scientific flaw with this. The proponents say there's a different phenotype. And I urge you, if you have nothing to do tonight, just Google different phenotypes of knee osteoarthritis. There are at least 4 or 5 of them. So the things that we know is a dry osteoarthritis, but there's some wet because synovial expression with a lot of fluid. And the one we see usually hypertrophic, but there's atrophic with a lot of collapse. So there's a different phenotype. And not to mention about, again, if you have nothing to do tonight, just Google neuropathic pain and knee osteoarthritis. In general, there's 20% of those patients exhibit the neuropathic features. You touch them, they ouch, they have pain all the time instead mechanical pain. And to the extent that there is Lars Nelson, my good friend, published, joint pain is not just a structural changes. There are some neuroplastic changes as well. So with that in mind, so you certainly need to tease out which one is which. And yes, in large center, the real life data, I emphasize in large center, they are actually seeing that the value of this. I used to have the straightforward rheumatology referral, osteoarthritis. No matter what, they just work. But when you are seeing more and more, the large data, real life data show that actually the success rate is 2 to 5 times more if you perform a prognostic block. Going back to this, the small trial, they say actually the design is actually to have block and no block. Well, it's not really a treatment. Treatment, you can have treatment and control and no treatment. When we talk about block, the block is not a treatment, period. Block is to help you, this prognostic block to help you to decide whether to guide you, whether it's a good candidate, but they may misguide you. So if you have nothing to do tonight, just read this article, how to consider or interpret diagnostic block. And basically we call 2 times 2 table. So we need to actually have everyone to do diagnostic block and whether positive, negative, everyone to do the procedure. Then we can talk about the predictability. So it's not the design that you have or have not. It's not the correct design. That's the design for treatment, not for a prognostic test, period. So where are we now? I think the answer is after all this analysis, very simple. The prognostic block is the tool. So if you have a patient straightforward, you can decide do or not to do. The tool is help you when you are a little bit uneasy, uncertain, when you think what we call the low pre-test probability. Patient that you don't think, you're not too sure that this will be a responder, then you will do this. Patient with different phenotypes, with a very angry heart, osteoarthritis with a lot of synovial fluid, psychiatric comorbidity, you touch a patient, they ouch, high opioid, they have opioid induced hypersensitivity, or those who have a surgery. And I'm going to touch base on the after surgery. There are different category of patient. Very simple. The second, optimal target. Well, the 2011, the article published that supermedial, superlateral, and inframedial is a free sports there. Okay, well, cool. And everyone follow. Everyone follow. So some years later, that the group actually I know he's a orthopedic surgeon from Cameroon, spent a few years sabbatical in Belgium, and did a fantastic study. And this study quite interesting. He said, "Wow, that is a wrong target. The target should be much more lower and way more posterior for supermedial, superlateral. And if you don't follow, listen to this. For supermedial, if you use the conventional target, your hit rate is 0%. But if you use my target, it's 100%. For superlateral, if you use the conventional target, hit rate is 1/3. But if you use mine, it's better, it's 2/3. I don't know how many of you actually follow the new target, but certainly not a lot because I talk to people around. But there is some merit about this. So, and it's quite disturbing because actually, so now we don't know what to do. Everyone doing the one above, not the one below. So we are here to look at the science. The science is very simple. It turned out that they are partially true. All the genicular nerve, supermedial, superlateral, they are coming from behind, so it's posterior. But when they land on the bone, here, they divide into 4 branches. Both supermedial and superlateral genicular nerve, they divide into 4 branches. Their landmark touch 2, sometimes 3, but 2 out of the 4 branches. The conventional landmark touch 1, both supermedial and superlateral. So you see, well, we should follow. But actually look at here. The nerve devices in the medius, the medial or lateral branch, they also send some branch to that conventional target. So now actually, if you do the conventional one, you get 2. Do the modified one, you get 2. Okay, so where are we now? Again, I stir up the pot to further controversy. I think actually it's very important to recognize, and I do a lot of dissection. I recognize in the junction between epiphysis and diaphysis, there's a lot of nerve there. And no matter what you pick, any pond, you will get some nerve. It's like a pond, a fish pond with a lot of fish. You cast anywhere, you get some fish. And when you decide to be in this spot, you gain some, but you lose some. Another spot, you lost some, you gain some. That is actually the real reality. So my suggestion is here. I would say actually if we do the landmark here, I would say the posterior 1/3 is where to go. But from there, between diaphysis and epiphysis, posterior 1/3. So between middle and posterior 1/3, that junction. And the most important is use a large lesion, whether it's bipolar, you want to use coup or strip. And for those who know me, basically 95% of my practice, I use chemical because think about the fish pond. You cast a line, you get 1 fish. You cast a net, you get more fish. So that's the reason why I use chemical neurolysis, fast, easy, and cheap. All right. The third is how many nerve and how should they be targeted? Well, there are so many RCT now and so many review. I published one of them and 2 of them. And basically this initial one, they say it work. But the recent literature really suggests it doesn't work enough. So philosophically, if you think about this, there's a lot of fish, there's a lot of nerve, 10 of them. And why we pick 3? I mean, it's a minority. If you have a government, you just have 3 seats out of 10. You don't say it's a majority. That's not a government. When you perform a procedure, pick the minority, you are not doing a procedure. And as a matter of fact, those real life articles, they all show that anything more than 3 is better than 3, period. Everything more than 3 is better than 3. This is actually an important randomized control trial. This actually is from my friend and from Thailand. they actually picked the free spot, that conventional spot. They took my advice. They actually make it a bigger lesion, bipolar in the free spot. They compare with putting local anesthetic and steroid. And in the whole year time, they look at pain and whatever outcome. There's no difference. I think if you pick free spot and do a true control trial, not the one that without intervention. So without intervention, that control trial have a placebo effect. But there's those who when you do a real control, you use free lesion. This is actually a good testimony that free is not good enough. So then what should we do then? Well, first of all, actually look at the literature. Actually, this is a very interesting article. Look at how many compartments. By now, you probably know, for those who are interested in knee osteoarthritis, there are three compartments: the medial and lateral tibiofemoral and the petrofemoral. So the medial petrofemoral is the one commonly done, and that free design is mainly to cater for those three compartments, especially for a medial compartment involved. But look at this, petrofemoral compartment is also common, especially in female. They have a more petrofemoral compartment. So in that case, you need something for the pectoral area, and I always add the nerve to varus intermedius, the medial and lateral branch. And in some patients, not a lot, they have a tri-compartment we need to design. So I think flexibility is important. So I usually use 5 nerve, and the 5 nerve is a free nerve plus the nerve to varus intermedius, this green thing here. So it's very easy. One 2-finger breath about the patella. You can use X-ray anterior 1/3 or ultrasound. You can always see this anterior here. Put the ultrasound probe. You always see a fascia expansion. You put a needle in the anterior 1/3 and you just get it done. So 5 nerve. But in case of patient with a lot of lateral disease, then you can add the recurrent fibular nerve and nerve to varus lateralis. Or when someone with the petrofemoral, you can add nerve to varus medialis and lateralis. So all this technique is going to be described in my article. The other one is about the technique. Well, people do fluoroscopy. What's wrong with this? If you cannot see anything wrong with this, I want you to be careful about your technique.
It's not a true lateral.
This is a true lateral, so you need to do it. As a matter of fact, a few key opinion leader in Canada and show in the talk, and they show the one on the left side. I don't know what to say. So when you do X-ray, you need to really have a true lateral, and so that, because otherwise when you put a needle, you are either too anterior, too posterior, and not exactly where you want to be. Okay, so fine. Actually, it's Dr. Peng. I know X-ray, so everyone know that. Okay, got it. But ultrasound, are we doing the same? Let's talk about some ultrasound common mistake. Put precision. I can pick any 10 article on ultrasound guided radiofrequency ablation. The picture is always like this, okay? And actually said there's a few coming from just this year. The picture is like this. And what's wrong? Well, they are not trying to do true lateral. We take their obsession in lateral X-ray, but when you do ultrasound, you are just sloppish. Sorry for this language. You're just putting like this for ergonomic reason. What you see basically is anteromedial or anterolateral. You are not seeing a true lateral. When you put a needle there, you'll be in the wrong place. When you put diagnostic block, well, doesn't matter. But when you use it for radiofrequency, I expect those put it for radiofrequency to be serious and make sure that you're doing a true lateral like this. Well, it's just a theory, right, Dr. Peng? Well, let's talk about this. This is an article, give you just something for reflection. This article, they adopt the Belgian approach. They deliberately put it in the posterior cortex on ultrasound. They just actually snap the X-ray, and 72% of them, they are in the anterior 1/3. Even though they deliberate with ultrasound, put it in the posterior cortex, like in the abdominal magnus. Something for you to reflect. So if you do sloppishly in ultrasound for local anesthetic, fine. But when you do it with X-ray, when you do it with a radiofrequency, I think you need to rethink what you're doing. So next time when you do ultrasound, and when you have an X-ray around, and you put the needle there and just have an ultrasound, put that with ultrasound and have an X-ray and see where you are. I guarantee you will be all over the place, unless you follow the next 2 tips. The second tip is actually we follow the vessel, right? So this is actually in a textbook. Well, if you have nothing to do tonight, just Google descending genicular artery. That's a systemic review. There's a lot of anatomists, surgeons love this artery, descending genicular artery. Just do a systemic look at the review article. In the junction between the diaphysis and epiphysis, there are three vessels: supramedullary genicular artery, the tibia branch, and the L branch. So basically, there are three different vessels. And when you see a vessel, it can be 1/3 chance you are doing supramedullary genicular artery. Again, there is articles when you follow the artery, you're all over the map. Don't follow the artery, period. That is the wrong idea. I have no idea why people think about this. The blind lead to the blind. Okay, the third is actually, I know I've been preaching this. So the typical way to do ultrasound, you find the long axis, you see the junction between epiphysis, diaphysis, and then turn 90 degrees. I urge you to do this technique. If you are experienced, you probably may be okay. If you are not experienced, when you turn 90 degrees, you put a needle, I urge you to snap the x-ray and see where you are. Because there's a lot of movement, you may not be in the right place. So the only thing that really got you is the bone signature, So I'm fairly obsessive enough to look at all the skeleton, all the MRI, all this, and snap all the ultrasound, look at the bone signature and correlate with X-ray. And there's an article coming out from Brazil that I asked them to work with me. So this is the bone signature when you go for medial and lateral. So when you go to medial, what you need is, so is this left-hand side is anterior, right-hand side posterior. When you look at the angle, the posterior, when it become right angle, so instead of curve, that means actually is a good spot. Because when you go further, you will see on the middle side, you see at the tubercle, on the lateral side, you see epicondyle. That's too far. This is a very reliable bone signature. If you put a needle there, you look at X-ray, you are happy. All right, so the last thing I would like to talk about is, should we do the RFA in post-total knee arthroplasty? And what should we know? Well, the total knee arthroplasty is a very successful procedure. And one of the very satisfying procedure, but we know that 20% of them, they experience persistent pain or dissatisfaction. We know this. And this even the surgeon agree. Okay, well, should we, what is the role of RFA in persistent post-total knee arthroplasty? So I do a lot of this because now I see complicated patient and the surgeon dump all the patient to me, so I see a lot. So basically, I analyze this for three different angles. One is a basic science. Well, remember, this is actually one of the famous article called from American family physician. They preach everyone that osteoarthritis is a common degenerative disorder of the arterial cartilage with hypertrophic changes in the bone. Okay, fine. So you take the bone out, take the arterial cartilage out, you are fine. There are many reasons. So actually summarizing the article. So for this talk, I just want you to do one thing. If you have nothing to do tonight, actually now it's tonight, but tomorrow night, just Google this. There's a very good article, or Google anything about subchondral bone and osteoarthritis. It really opens your mind. And it's a very difficult article. So basically, the cartilage is a vascular, a neural, no nerve, no vessel. So let me zoom out the picture here. All the longevity of the cartilage and the superficial and subchondral bone, they are supported by the very intricate network with a lot of osteocyte, precursor, the vessel, the nerve, and the immune cell to control the harmony homeostasis of this. And that's why osteoarthritis can common is not just mechanical stress, but also in systemic disease as well. All right. And I want to focus, actually, there's a lot of immune cells there. So the immune cells, when you have a continuous stimulation damage, you can cause stimulation of the immune cells and they can sensitize the nerve. There's a very intrinsic network there. And there's a lot of vessel there. And for healing, they build the bridges. That means they send the army there by sending more vessel there. And that's the basis for embolization because it's a neovascularization. So that when they embolize, a lot of misunderstanding is they don't kill all the artery. They kill the new vascularization. So when they have more mechanical stress, they build more new vessel. Okay. And most important is a nerve. There's an intrinsic network, actually published by Marshall DeWall, and this intrinsic network. Think about this: if you have such a dense network, when you have a lot of stimulation in subchondral bone, you can actually have a sensitization. Sensitization. So when you remove the cartilage and a little bit thin layer, you are basically exposing your network of nerve. And very similar to you have a dental problem. Initially you have an enamel, but when your enamel have a decay, you expose the dentin. It can be quite sensitive. It may be the case. So, and in some patient it's okay, some patient is not okay. It depends how sensitive it is. So what I'm trying to say is the osteoarthritis is a complex condition involving change in subchondral bone with local inflammation in the synovial swelling as well, synovial line, and there's a adaptive and innate immune response in the subchondral bone, neuroinflammation, central sensitization, and interaction with the epigenetic and pathological process, and not to mention the psychosocial aspect. So I'm trying to convince you that the need that you see after osteoarthritis can be different in the for the native osteoarthritis. So, and this is actually important to understand. So when you have a patient after total knee of osteoarthritis, and that may be after total knee arthroplasty, they may have a change. But anyway, so the understanding of the pathophysiology of the osteoarthritis is important because it shows you why there's the correlation between the radiology and the clinical feature is unclear, basically, because sometimes you see a bone collapse, sometimes you see a thinning of the cartilage, and you don't have much symptoms. Sometimes you see not much cartilage wearing, you see a lot of clinical features. There may be another reason. And that may explain why the persistent of pain despite removal of the neuroavascular cartilage and a superficial subchondral bone. And that is the things that I want to bring out. Is crucial to identify who is a responder. Clinical evidence. Well, there's a systemic review published in 2022, look at all the radiofrequency for those patients with post-total knee arthroplasty persistent pain. Well, before you actually read the conclusion, I want to direct this. 11 study, there's another actual publication published in 2021, the same topic. Again, same number, 11 study, except one, they are all retro and case series, and they all say it worked. Well, let me just give you a simple understanding about case report and cohort. They are like gospel, like a Bible. They spread the good news. Because it's not good news, they don't publish. So it's not good enough. But there's one study in this case, in this systemic review, which is a RCT, and I want to discuss with you. This is actually from Spain. Actually, I know most of them. Maria is my good friend. So this is a randomized controlled trial. They compare, so they are all post-total knee arthroplasty. So they actually, one group is traditional radiofrequency, and the other is local anesthetic and steroid in that free area. They don't put the diagnostic block, by the way. So, and there's no difference. There's no difference compared with basically a control group with local anesthetic and steroid. But you can argue local anesthetic and steroid is not a control group, but they actually follow up to 12 months, and there's no difference. This is probably the latest cohort published recently, and around 180 patients. Again, this is a retrospective review published after that systemic review, but it's a large one I want to discuss. They say that this cohort support the finding that those with history of TKA under this have 70% lower odds achieving a good subjective score. So how to manage this group? I think actually we cannot just actually burn all of them. I think most of our patients that refer to you, they already seen by the surgeon, assess the prosthesis problem, scar problem, infection, so they refer to you. I always divide this into two groups, tangible and non-tangible. Tangible means actually you need to explore some other things, even though the surgeon say there's no loosening. The intra-articular, one of the common thing is the lateral patellar impingement. Do the sunset or sunrise view, see whether it's impinged and then treat accordingly. Or extra-articular, and how many times I see is infrapatellar neuralgia, 7 to 30% of them. So their pain is superficial. And again, I have a review article. Actually published by my son, Michael Peng, on everything you need to know about infrapatellar nerve neuralgia. Or they can have just a ulcerative bursitis, so you treat accordingly. A lot of time you don't, so they can be from various reasons, but the most important part is to do a diagnostic block. The prognostic block is important, um, and am I just talk about opinion? Well, let's read some science. So for those literature with focus on the persistent post-total knee pain, this is a study I showed you before. Without prognostic block, there's no difference with control. But when you actually have a prognostic block, they always show a difference. I think that is the bottom line is you need to do the prognostic block for those with total knee arthroplasty pain. So this is a take-home message. I think prognostic block is a tool. You don't have to do it, but use it when you think there's a low pretest probability, like huge opioid psychological morbidity, or those with a total knee arthroplasty, etc. The landmark, I think, is okay, but in general, I would say we need to focus on the junction between middle and posterior 1/3 in between the epiphysis and diaphysis, and use a large lesion. For me, I use alcohol, so once I nail in the area, put the alcohol, I'm okay. More nerve is better. I always do 5 or sometimes 6, sometimes 7. Depends on the disease load. If the patient have significant patellofemoral disease or lateral femoral tibial disease, I do more. I think need to improve your accuracy of imaging. Whether you use X-ray, ultrasound, need to rethink what you are doing. A lot of time your ultrasound, you just see, you think what you are seeing. It's not the case. I'm serious about my ultrasound skill, and I hope all of you should pay attention to the ultrasound accuracy. And persistent post-total knee arthroplasty, my suggestion is patient selection, patient selection, patient selection. Make sure that they are not the tangible one like the infrapatellar neuralgia, pes ulcerinus, or actually the impingement from the patellar facet, and then to do the diagnostic block and go from there. So again, I try to make it short, and what time is it? 35 minutes. So I leave a little bit time for Q&A, and I want to stop in 25 minutes so that everyone can enjoy Sunday night. Thank you very much.
Dr. Peng, thank you so much. Thank you so much for this wonderful lecture. You covered in 30 minutes everything about starting from the prognostic block, the latest about the knee innervation, the targets, ultrasound guided technique, how to do this bony signature, post decay, and everything is covered. There are a few questions in the chat box also. I'll go to that. But in the meantime, I do have a couple of questions like no. Do you do this infrapatellar branch as well as the recurrent fibular nerve also in all the cases, or we do not have to do that?
Sorry, I missed. Do I do the?
Do you have to do this infrapatellar branch, target the infrapatellar branch and the recurrent fibular at the same time, or you don't have to?
I am not a believer of infrapatellar branch. I know a lot of people do, so let's do it. Fine. So the rationale is so that is actually in the original article. I did not touch base. Since you asked, I can touch base on this. So it will be another controversy. So first of all, I don't think infrapatellar branch is a major contribution. It's more cutaneous, and so there's argument. Fine. And so the argument say actually one of the articles say is 100%. I argue is not 100% because actually when you do the dissection, as soon as you peel off the skin, so you you see something on the capsule, but you detach from the skin. You see something on the capsule does not mean is innervating the capsule unless you puncture the capsule and see whether it infiltrate. So we did actually, so we find that actually is probably a minor contribution. It's a sensory nerve. But then the people say, well, then people do all this infrapatellar intervention and that get a good result for osteoarthritis. Then I caution you, this is in my article, so I can summarize for you. If you use it for those articles, just use infrapatellar nerve as a target. They use pulse and they have a very good result. And that is not a denervation, that is a neuromodulation. You can pulse, you can actually stimulate any nerve and causing some relief. and that is actually neuromodulation. The same thing as you can stimulate the tibial nerve for bladder overactivity. So that is not. But if you use it for denervation, and there is summarized evidence, the denervation of the infrapatellar nerve does not improve the outcome acting this nerve. So anyways, just actually that's in my article. And I look at all the literature. So people try to mix everything up and have the argument. So I'm here to undo the controversy about this.
Okay. So what about this recurrent fibular nerve? People were earlier scared about doing this recurrent fibular nerve for the sake of
That's not true. So if you don't, means actually you scared about this, means actually you need to read my article about the anatomy. The recurrent fibular nerve and the fibular nerve, they are like Atlantic and Pacific Ocean. So the fibula head, so this is a head of fibula. The target is anterior to the fibula head, and the fibular nerve, the motor one, is posterior. So this is North America. We have Atlantic and Pacific. You're coming to talk about two different areas. So the landmark, there's two landmarks for recurrent fibular nerve, and no matter what, is so away from the nerve. One landmark is used just below the girdle which I don't like it, but the one that I suggest is just anterior to the widest part of the fibula head at the junction of the tibia. That is what the American group described. But one caveat about this, I will not do it under X-ray, because if you look at ultrasound, that spot basically is where the superior tibiofibular ligament is. Ultrasound will get you just a little bit away from this. The X-ray technique just burn the ligament, not to burn the nerve. If you have any misunderstanding, read my article, hopefully coming out in July. And so I don't buy it have a motor. It's like Atlantic and Pacific. If you think about this is a problem, you should revise your anatomy.
Okay, I was asking for this audience. Somebody had asked you, and we can safely do a thermal RF ablation in that area. We don't have to worry about the foot drop, all those, correct? There are some
Yes, if you
questions.
follow my technique. So that's one of the key opinion leader keep asking me and come to even shadow me, and I show them properly, because he say he get the motor stimulation. I say, no way, Jose, you cannot. So after he come and learn, he's okay now.
Okay, so there are many questions. A lot of them have thanked you for this wonderful lecture. So one question is that kindly elaborate on the use of chemical neurolysis for genicular nerves. How much percentage of alcohol and volume, and how many sessions?
So I'm not give out all the secret, but give you 3 tips here. So the number one is the genicular nerve alcohol is easy, fast, and most important is whatever you do the diagnostic block, you give 1.5 cc, you are giving the same volume. So it really predict what you are doing. So that's number one. And number two, I used to use alcohol. There's no problem if you can use phenol. As a matter of fact, my first study in Brazil used phenol, but the only reason I use alcohol because in Canada, this country, we cannot get a good phenol. We get aqueous, 6%, which basically is not really good. We get the glycolated 7%, which is good, but the hospital say is not up to the hospital standard and stop me from doing this. And phenol, you don't need local. You just put the medication there. Alcohol, you need to put the local. And I wait for 3 minutes so that it absorb, soak in the nerve, and then I put the alcohol there. So when I do the 5 nerve, I usually do 3 nerve and put a hydrodissect with 0.5% bupivacaine, and then just crack one joke, and then we'll be 3 minutes, and then go back and do the alcohol, and then do the next 2. Crack another joke, and just actually go back to the alcohol. The from start to end is less than 20 minutes. It's very fast. One of the things is when you try to teach your trainee, be careful. So these 2 things, these 2 caveat. Myositis is one of the things you don't. You don't keep puncturing this, because when you puncture the muscle many times, the alcohol can sit back to the muscle with those channel and cause myositis. The second is make sure you do the hydrodissection, which you are going to use local anesthetic to numb the area. Make sure you are not inside the muscle, you are actually in the plane. And the third is actually for inframedial. That is the target is just deep to the medial collateral ligament. Use 0.5 because in skinny individual, it can spill off and you can create a infrapatellar neuralgia. So I use every place 1 to 1.5 cc, depends on the size. I used to use 1 cc. Now I can use 1.5 for big individual, except the inframedial genicular nerve. I use 0.5 because I just don't want to spill out. So that's all
Okay.
the clinical relevance.
Okay, so here I have a questions. Like for all those, I say about the medial compartment, like anteromedial compartment, for the chemical neurolysis, you put one cannula towards the adductor tubercle and then withdraw, do at the mid portion of the shaft. Is that the correct approach? One is to
No,
no,
no.
no. So you just do at the posterior one third where typically those deep branches run, and then one little anterior one third where the nerve to the vascular
Okay. So
intermediate.
again, I apologize. So it's impossible for me to teach you all this. It's in the article. So let me just summarize. 5 target. The first 2 is nerve to varus intermedius, which is an important contribution for superior talofibular joint and also the patella. So the landmark is 2 finger breadth above the patella, and then anteromedial or anterolateral to the femur. So when you look at X-ray or ultrasound, is in the anterior 1/3. So if you look at the lateral X-ray, it's 33%. The supermedial superlateral is at the junction between the epiphysis and diaphysis, and the lateral X-ray is in the 66% or 70% if you want to. So that's 33%. So for the lateral, it's 33% for the nerve devices intermedius, medial lateral. Supermedial superlateral is 70% from the anterior. Okay, and the inframedial is straightforward. I hope I clarified the misunderstanding.
Yeah. That's clear. That's clear. And there are few more questions like how long does the relief last from a perfectly performed alcohol neurolysis? How long does it last? Like 3 months, six
So
months?
the published cohort actually is we follow up 6 months, is around 6 months, but we didn't follow long. And I think for my series is around 6 to 9 months. And the radiofrequency is also 6 to 9 months. Well, I do have patient last for more than a year, but the bulk of those, they are very similar. And alcohol I can repeat easily. And radiofrequency, I do radiofrequency. Actually, I do actually on the medial. I actually a lot of time I put 2 even 3 needles for bipolar, but it's so time consuming. I just actually change the alcohol. I still do
Yeah.
radiofrequency for a few things. Nerve to varus medialis, nerve to varus lateralis, and recurrent fibular nerve. I do it because it's between the muscles, so I have to use radiofrequency.
So there is a question, is there any role of a sensory and motor nerve stimulation before ablation? Do you do a motor and sensory stimulation unlike a facets or trigeminal? Here, is it advisable to do a sensory stimulation or motor stimulation?
Okay, so for there's two type of genicular nerve. Okay, for those who actually I can tell you, for I'm obsessive in looking at anatomy. There's 2 type of genicular nerve divided by the location. One type is between the bone and some soft tissue. Basically, the nerve varus medialis, medial and lateral branch, nerve varus intermedialis, medial and lateral branch, supermedial, superlateral, inframedial. They are all this type. They are actually between the bone and something. So I do alcohol, I don't even do a test. And when I do the radiofrequency, I don't need to do a test because they are on the bone. If you actually remember, when your nerve land on the bone and you are thinking about there will be a motor stimulation, it's just a joke. But you only do this when you are not comfortable where your needle is. But I would say if you are not comfortable where your needle is on the bone or not, you should not do it. There's another type of genicular nerve. They actually they still in the intramuscular or soft tissue plane. They don't give up. They don't give up until just above the tissue. They just above the capsule. They dive in. There's nerve varus medialis, nerve varus lateralis, or actually is the recurrent fibular nerve. That's the one that I do radiofrequency ablation, and that's the nerve that I would do the motor stimulation. No sensory, just motor stimulation. That's it.
So there is another question. Do we need to target the genicular nerves for acute pain relief after TKA when you are giving proximal adductor canal block or a digital IPAC?
Okay, so the question is difficult to understand. So are you talking about pre-op or post-op?
Yeah, this is something I think this is post-up they have written after TKA, then it's difficult. It's not possible because that area is already covered from the surgical, all those things. So that is not
Well,
possible.
I give you a few perspective. The post-op, first of all, actually, if you have pain, I will wait because actually, it's a lot of time. We also see the patient in we have a transition pain unit here, by the way. So we see patient after terrible pain, after surgery, chest surgery, or any surgery. So not until 3 months that they still have a chance to get better. Okay, that's important. And so you don't do ablation in the 3 months because there's a possibility they settle down. The second, if you want to do this, you can do abductor canal. So for those who read my article, abductor canal have only one nerve, which is the seventh nerve. But the difference is when you do abductor canal block, you are not blocking one nerve. So I just want to make sure inside abductor canal, there's only one nerve. But when you do an abductor canal block, you are not blocking one nerve. So think about your toilet paper. You know the cone at the end. So abductor canal is like a cone. You put it there, the medication leak out from on both sides. My article suggests that even 10 cc, you block 7 more nerve, including nerve velocus medialis, supermedial genicular nerve, the posterior branch of the obturator. So you block another nerve. So if you want to do this, you can use a high volume. Think about this: 10 cc, you block so many nerves. 20 cc, you flood the whole area on the middle aspect. So sure, why not go ahead and provide some temporary relief until the patient can have rehab, can have some pain medications kick in. Sure, you can do it, but I don't think we need to do the radiofrequency ablation or anything until the pain settle down, until the 3 months afterward.
Yeah. Is there any role of genicular blocks for the acute pain relief in the pre-op setting for a TKA?
So there's two things here. Okay, so for those who ask this question, need to think deep. So the first article was published in Duke, and this is my idea, but somehow no one in our center do it, so I just give it. So you can do genicular nerve block instead of abductor canal block, all these fancy things, because it covers more nerve. So suddenly you can do it for acute pain as a regional block and with high volume. The Duke article actually give fancy big volume there. You basically talk about 15 cc, you block everything. Basically, it's a pericapsular nerve group block. The genicular nerve block is not a genicular nerve block. With that 15 cc in each column, they are pericapsular nerve group block. They block every single nerve that you can see under the sun. So it's a good regional block. This is the first question. So you can do it instead of abductor canal, and there's some study already done. The second question is there any role for cryoradiofrequency ablation or anything that is permanent, do it before maybe a few weeks, few days before the total knee arthroplasty? Well, there is 3 article or 4 article published, and most of them they don't see a difference in terms of shortening of the rehab, shortening the rehab, decreasing the chance of a persistent total knee arthroplasty pain. Except one article showed there's a difference, but the article was published in McGill, present as a #1 abstract, but they did not actually pursue and write the full article. So it's dumped in the trash now. So most of the article they show there's no difference.
So somebody has asked what percentage of alcohol can be used, like absolute 100% or 70 to 80% or
So I use 100%. So this is medical grade. When you go to any store for chemical, you only get 95% because it absorbs the moisture so much that it becomes 95% automatically. And that's the anhydrous properties that we imagine you put it beside the nerve, it dehydrate the nerve. So medical grade get you 100%, it's still within a ampule. So it's 100%. So I usually use 100%. The reason for this is very simple because it hurt. So I usually preempt the area with the same volume. Say I put 1.5 cc, 0.5% bupivacaine, and then wait for 3 minutes. So it disappear, and then put another, and then I put 1.5 cc alcohol. Well, if I put one and I put one, if I put 1.5 and I put 1.5. So basically, there's a chance it dilute already. So I don't want to use anything cheaper than this. So I just use 100% alcohol. In Canada, it's so that cheap. It's like $10. But in US, my friend tried to tell me they are using my Peng block for inoperable hip fracture. It costs them $600. I should
Oh,
smuggle some in US and just make a big sale. I don't know why, but I don't know how much it costs in India. Hopefully, it will be that cheap, like $10
yep.
again.
Yeah, it's cheaper here. It's cheaper here. So there is another question. What is the given a choice between this phenol and alcohol? Which one would you prefer? Which is preferable? Like no phenol or are they equally effective, both of them?
I think actually it's both. If I have glycerated 7% or above, I will use it because it's faster. I don't even have to wait. But I just don't have a formulation. So that's the reason why I use alcohol. So I think both are very good neurolytic agent, have a very good robust. It's just because I just don't have that access here. My hospital won't let me use glycerate at 7% or above. If you have those, go ahead. I produce good result with alcohol, so now I don't bother to change.
Okay, perfect. So whatever is available, locally, whatever, both are
Yeah.
equally effective. So there is one question from Dr. Singh from Singapore. Excellent lecture. May I ask you, do you do NPI, enough to vastus intermedius medial or lateral branches chemoablation since it is present in one-third of patients?
Sorry, do I do this in?
Not to vastus intermedius medial and lateral branches, which is one of those innovation you talked about, two finger blades proximal to the patella and doing that.
Yeah,
Since
so
it
I
is
do it all the time. So that's I do it all the time. So I do I do five nerve all the time. So am I misunderstanding? So I do the nerve vascular intermediate, medial, and lateral branch as part of my total protocol for everyone. But I add recurrent fibular nerve devices intermediate or medialis in some specific patient when they have a different compartment disease.
so. What is your opinion about non-invasive pulse radiofrequency for the knee pain? There is a stim-pod machine available, similar to a TENS machine. Have you used that? Do you have any experience? Somebody is asking that
So
question.
I use the pulse frequency for the osteoarthritis of the knee?
Yeah, so that is again a non-invasive, not an invasive one, like a similar kind of a TENS one.
Yeah, yeah. So I don't want to give out. So today I talk about five controversy. In my article, actually six of them, and one of them actually developed the whole topic on this. So please, when the article is out, look at all this. I can give you, but I can give you a little bit of preview. I already answered this question. The pulse is not really a denervation technique. It's actually neuromodulation. So there's two ways to look at this. One is that when you use a pulse, the literature suggests just pulse for only one nerve, only one nerve. There's 4 RCT on this, and there's six of those case series. They all work, but they own on one nerve. So as I say, and I don't know whether it's true or not, but I cannot say no. But uh, the criteria is post-total nephroplasty. I don't know how many of them they are actually intrapatella neuralgia patient. So they all work. But as I say, when you do pulse, you can it's a neuromodulation. You can pulse, you can stimulate the tibial nerve. You can treat the overactive bladder. You can stimulate the ear and for addiction. So it's all over the map. There's no science, but purely from genicular nerve, there's literature to show that the pulse in those area does not uh, pulse with multiple nerves. So there's a different trial. You use pulse for supermedial, superlateral, inframedial. Compared with the true radiofrequency, the radiofrequency is way much better than the pulse. So it's a little bit strange. It's the best I can tell you. But in my article, it says for a pulse, you have two types. One is to pulse as if you do the denervation. It didn't work as good as a true radiofrequency ablation. But the pulse on just one nerve only, they work really well. And I cannot explain, but I think there's something strange in that those literature.
Okay. What is your experience on a post-total knee arthroplasty severe pain persisting for a year on getting up from a sitting position due to patellofemoral syndrome?
So
Somebody has asked this
my
question.
my 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 question is, Well, do you remember that algorithm? So you see quite a few. We still see those actually. I'll give you one scenario: patient with 1 year of those persistent pain, and they are quite anterior. They say actually the pain is mechanical, mainly when they walk stairs. And then when I do the examination, is mainly a particular spot on the lateral aspect of the knee, and then do the sunrise view. And actually, you for those who should know is when they do the total knee replacement, they don't replace the patella. They put the tiny plastic cap. They drill a concise hole, put a plastic cap. The cap have to be in the perfect position. If it deviate, you can push the patella one side or the other, and then to exaggerate those impingement. And so in that case, what I have to do is simply just do the nerve vastus lateralis. So I have 3 patients that I'm actually writing a case series on this, and just simply do the nerve vastus lateralis with or without the supralateral genicular nerve, and diagnostic block, take away the pain, and do the radiofrequency and take away the pain. So for those particular category, you may. Now, if they are actually not from the simple impingement, they are from sensitivity and they're from central sensitization. Well, I don't know. The only way I know is to do a diagnostic block. If they are not responder, and I don't know how to deal with them. So that is a sad thing.
Yeah, that's a difficult category of patients actually, no? Okay. So somebody has asked these questions. Do you put steroid after alcohol injection?
No,
No.
no,
No,
no. So,
absolutely
so,
no.
so it's like a thief. Once you steal something, you get away. So once I put the alcohol and I flush with the
Yeah.
local anesthetic, take it out. Get out as soon as possible. Don't put anything there. Yeah. So
Yes.
no, no,
Right.
no,
Yes, yes. Okay. Can we do genicular RFA under spinal anesthesia? Why? Why under spinal anesthesia? Somebody is
no.
no,
I
of
just
course no.
talked. So what you can do is crack a few jokes or actually talk about your research. Patient will fall asleep, so you don't need spinal anesthetic. So don't worry.
Mm.
I never do it under spinal. So basically, it's a procedure with sedation. I've done without sedation as well. So it depends on the patient. I don't think we need to give a major anesthetic like spinal. No.
Yeah, I think you have answered pretty much all the questions. There are quite a bit of overlap between some of the questions, and you had some, I think, some yoga or something you mentioned about something to do. This is Sunday morning in Canada, and thank you very much for joining us. Really appreciate it. It was an honor to have you here, and all of us has have experienced, have benefited from this talk tremendously. I must admit that despite all those advancements, despite doing this technique so meticulously, knee is actually a challenge. Actually, we still face patients, presenting after a month or 3 months later with some pain. They're not satisfied with the ablation or even if the chemo neurolysis also. So it is a challenge, but we are improving with the new insights from you guys, all those dissections, the wonderful lectures, the papers that you guys are producing. Thank you very much. Honored to be here. Thank you.
Thank you very much. And so I finish on time. And as I say, sometimes I use a little bit harsh word, but basically just my intention is good. Just actually have you to think about if you so the I finished this talk by quote one of the editorial from Stephen Cohen. He say actually the pain medicine is still a developing medicine, so it's ongoing. We need to refine the technique, and this is what we do. Now we have a lot of interest, and we need to refine. And don't stick on the technique that people say 10 years ago. And there's a lot of things need to improve. So, and that's my job here to stimulate and argue some of the evidence, some of the opinion, and hopefully we can all improve our technique in the future. Thank you very much.
Absolutely, absolutely. Thank you so much. Thank you so much. Hopefully, we'll have you in the future also for some other lecture and some other topics. Thank you very much again. Good night,
Okay,
friends.
thank you. Bye.
I hope all of you enjoyed. Thank you.